Dear panelists, ladies and gentlemen, my PhD takes a translational approach to the prevention of diabetes after acute pancreatitis and in prediabetic individuals. I'm Olga Zahariev, a UK-trained dietitian, currently working at the Division of Pancreatic Diseases. My vision is a world where preventable diabetes is prevented, and my mission is to shift health policy towards prevention and to educate patients. I will use different approaches to explore diabetes prevention. The first one is identifying patients at risk of diabetes after acute pancreatitis, and the second one is an interventional study in patients who had acute pancreatitis. So the first project, acute pancreatitis has been believed to be causing only a temporal imbalance in health. However, 1 in 5 patients go on to develop diabetes within the first 5 years of acute pancreatitis. Moreover, diabetes has a huge health and economic burden on society, yet 3% of post-acute pancreatitis diabetes patients are diagnosed correctly. So there is a large number of patients who are not caught, and they are thought to be type 2 diabetes patients, and this is problematic because these patients who have diabetes after acute pancreatitis have a larger mortality rates, more likely to have poor glycemic control, and have to commence insulin therapy much earlier compared to type 2 patients. Therefore, the aim of the first project is to identify patients at risk of developing diabetes after acute pancreatitis. So the patients of interest are those who had acute pancreatitis but no diabetes at the point of discharge. We compared various biomarkers to their absence, such as etiology, necrosis, obesity. And the outcome of interest is new onset diabetes or prediabetes. We believe that diabetes develops significantly more frequently after pancreatitis that was severe, necrotic, or caused by hypertriglyceridemia. Systematic search has identified nearly 12,600 records, of which 45 studies could be included in the analysis. Like many of my colleagues, we have lots of results. However, to briefly summarize all of this data, I will be showing you aggregated forest plots. So to guide you around my slides, you see the pooled odds ratios for each of the risks. So you can see that severity is a risk factor here in various combinations, and the pooled odds ratio is on the right side of it. The outcome is expressed either diabetes or prediabetes, and usually a combination of prediabetes and diabetes mellitus for those studies who could not and did not differentiate between these two entities. And an odds ratio over 1 will indicate that there is a higher risk of developing dysglycemia within the exposed group, which is always in the first column of my slides. So figure 1. You see that having severe or moderately severe disease progression is associated with significantly higher risk of developing dysglycemia, and that the association is more prominent for the combination of prediabetes and diabetes mellitus compared to simply diabetes. Figure 2 shows that having necrosis or pseudocyst formation is associated with a significantly higher risk of developing dysglycemia. And we also found a tendency for recurrent pancreatitis. However, it did not reach statistical significance. We were surprised by this finding because most patients who have recurrent episodes are usually those who had severe disease progression, and the previous slide just showed that having severe is associated with increased risk. And also patients are usually having alcoholic or hypertriglyceridemic etiology. And now leading on, we see here that having hypertriglyceridemic etiology is showing a tendency of 3.27 greater risk of developing dysglycemia, but it was not statistically significant, likely due to the small sample size and low number of studies included in this study, in this comparison. Now, alcoholic etiology, however, was statistically significantly increasing the risk of developing diabetes. On the other hand, biliary and idiopathic etiologies, which are less toxic compared to the other two, are associated with a significantly lower risk of dysglycemia. And lastly, we have found no significant association with comorbidities or demographic factors. However, it's important to highlight that it's only including and pooling data from small number of studies, and one of them is a large nationwide study that is messing up the results. So it needs to be repeated. In short, the strength of the study are it is the first comprehensive meta-analysis on the topic. It uses robust methodology, and it has some large pooled sample sizes. However, the outcome was very heterogeneously defined, and there was various follow-up lengths of the studies as well. Therefore, we included subgroup analysis. And the last important point that I mentioned regarding the comorbidities was that many of the comparisons was basing studies only on were pulling data from only 3 studies. So in conclusion, having severe or moderately severe disease progression, alcoholic etiology, and local complications are associated with significantly increased risk of developing dysglycemia. We have also found a tendency with hypertriglyceridemic and recurrent pancreatitis patients, male sex, and some of the comorbidities also showed some tendency. On the other hand, having biliary or idiopathic etiology is associated with a lower risk of prediabetes and diabetes development. So in short, while everyone should be monitored for glucose homeostasis after acute pancreatitis, at least those patients who are in the high-risk group should be monitored. Future research should be focusing on identifying preventive strategies for diabetes after acute pancreatitis. And that's kind of, publicity first. So we have made it to a couple of conferences, and the manuscript writing is in progress. Hopefully it will be a good present for my supervisor, and we are aiming to submit to the Lancet. So the second project is leading on from the first. It's an interventional study where we are using dietary intervention of reduced fat, and we are looking for endocrine insufficiency later on as well. But there are many more things we are looking at. So acute pancreatitis, many of the patients, 25%, go on to have recurrent episodes, and 10% go on to have chronic pancreatitis. There are some preventative measures, for example, abstinence in alcoholic pancreatitis and cholecystectomy in biliary pancreatitis. However, all patients are advised to follow a low-fat diet endlessly, and there is no actual behind it, no actual evidence behind it. So what we are looking for is to conduct a randomized control trial to test the effect of dietary fat reduction after acute pancreatitis. The study that we are designing, actually we have designed and started. So the 2 arms are 15% fat content of the total energy intake, and the other arm will be advised to consume 30% of their total energy intake from fat. The protein content will be same in both arms, and the carbohydrate will be adjusted. We are aiming to enroll 200 patients, nearly 200 in each of the arms. The outcomes we are looking for, the primary ones are all-cause mortality and recurrent pancreatitis, and the secondary outcomes include mortality, chronic pancreatitis, some serum lipid markers, body composition, dietary adherence, adverse events, and quality of life as well. The study is lasting 2 years, so the patients are asked to continue the diet for 2 years. When they come to hospital, we assess their eligibility, and we collect the baseline data. On their first visit, we have checked between these 2 points that they are really, really idiopathic patients. And then on the first visit, we do the allocation and start the intervention as well. We see them 6 times throughout this whole period. And this was asked by the patients to have a more frequent visit with them initially so that they are more comfortable with the guideline and with the intervention. So this is the timeline, and then at every one of the visits, we do laboratory testing, we do lots of questionnaires, we do a body composition test, we ask the doctors to see the patient who completes the ultrasound and checks the blood workup. We also collect blood pressure, heart rate, and hand grip test data. We do the diet diary, which is the gold standard at the moment, and we do the dietary intervention as well, answer any questions that the patients have. Our team have developed the dietary intervention, and as of yet, the protocol has been published. The internal protocol has been written. We have revised the ethical approval. The staff has been trained. Patient education materials have been developed. First patient was enrolled in May, and out of the 7 eligible patients, 7 came and were enrolled in the study. On the diagram, you see the number of visits. Obviously, we will have 6 visits there, but since we have started fairly recently, we only show the first and the second visit. It's quite a good attendance rate at the moment. So all in all, in the end of my projects, we will know how to identify patients at risk of diabetes after acute pancreatitis, and we'll be able to determine if dietary fat content affects acute pancreatitis recurrence and progression to chronic pancreatitis and endocrine insufficiency. I would like to close my presentation with a quote from Thomas Edison: "The doctor of the future will interest his patients in the care of the human frame, diet, and in the cause and prevention of disease." Thank you very much. The floor is open to questions.
great talk. I open the floor for questions, and while you are thinking about your questions, can I just ask you which type of diabetes is the most common after acute pancreatitis, and when is the peak? When do you see the peak of detection of diabetes post-acute pancreatitis? Is there a certain time frame in which it's the most common to detect diabetes, or, yeah, those are my questions. Thank you.
Thank you for the question. So for the answering for the second one first, 2014 there was an article which assessed the prevalence, and they found that in the first year there is a significant increase, and then for the 3-year mark it's kind of stable, and then it's rising again after the 5-year period. Also, there is a slight tendency in our data with severity that the more severe, the larger the odds ratio in the first couple of years, and then it kind of tapers off. So we expect that the early rise within the 1 year is likely due to or in correlation with the severity, and then the one after the 5 years is probably some other mechanism kicking in that could be causing that increase. Regarding type 1, type 2, type 3, it's even the terminology is not fully decided for type 3 diabetes. So there is disagreement in the literature. It's not, so the point is that there was this study that has shown that only 3% are characterized properly as post-pancreatitis diabetes mellitus cases. So I can't really answer that question because most of the data and most of the doctors don't really diagnose it correctly. So we don't know that, how many.
I'll tell you something interesting then, because we are thinking about a project in this topic. And so Mikko Sandi has got longitudinal data on the goulash cohort, and she says that, interestingly, the most common form of diabetes post-acute pancreatitis is actually type 2 diabetes instead of pancreatogenic diabetes. And that leads on to my next question. Is there any role of BMI in the risk of diabetes after post-acute pancreatitis, or other well-known risk factors of type 2 diabetic?
The problem is there is no clear-cut definition yet for post-pancreatitis diabetes mellitus. So there are some researchers who hypothesize that you need exocrine insufficiency markers as well. Some say that you need imaging that shows chronic pancreatitis signs, but there is no agreement on it yet. So usually what they say is after initial acute pancreatitis episodes, 3 months afterwards, if you catch diabetes mellitus, it's kind of termed post-pancreatitis diabetes mellitus, but it needs to be developed standardized definitions.